PID with like a late, you find out about it later. That's what I understood. I don't know, never mind.
Well, with
If it's already too late.
gonorrhea, in 3 days, you're already having a discharge.
Oh, so you can catch this before it gets worse.
Mm-hmm. Mm-hmm.
Okay, I had understood that PID is pretty much like already, it's too late.
No, it's any pelvic infection. Now, it can be caught early, or it can be caught late. If it's caught late, I can have Fitzhugh Curtis, okay? If it's caught early, I can just have endometriosis. Okay, either way, if I have an inflammation of my uterus, I'm gonna have a discharge. Okay? So acute, meaning, oh my God, I woke up this morning and my pelvis hurts so bad. Okay?
Mm-hmm.
Am I gonna call the doctor? Probably not.
No.
I'm gonna probably wait until 2 or 3 days before I call the doctor. So you're gonna have a mildly enlarged uterus. Why? Because the inflammation of the endometrium makes it swell. The endometrium is gonna be thick, it's gonna be heterogeneous, and it could contain fluid. If you have fluid inside the endometrial canal, you do not measure the fluid. You only measure the tissue. So that's anterior tissue, skip the fluid, posterior tissue. Okay? The fallopian tube changes. You can have, they can be thick. We call that adenomous, meaning they're swollen. And we can see the wall. It will be less than 5 millimeters. Because normally we don't see the fallopian tubes, right? Okay. But we can see the fallopian tubes if I have a hydrosalpinx, or if I have a pyosalpinx, or if I have a hematosalpinx. Okay? Now, for me to make the diagnosis for a fallopian tube, I have to see this septa, or a haustra. Okay, H-A-U-S-T-R-A. Okay, here is a hematosalpinx, a pyosalpinx with fluid. So I'm documenting my septa. So I'm gonna measure it from here to here, inner to inner, inner to inner. Now, this looks like it's layering. What am I going to do to fix that?
When you say layer, you talk about fluid.
See how it looks like it's layered right here? Do you think that's in the patient's body, or do you think that is imaging? We don't know. You'd have to be there to be able to see it. But because it's too uniform, I'm gonna turn it on to harmonics first, because it makes the anechoic structures more anechoic. Okay? And then I'm gonna work with my TGC just in this area right here. I'm gonna do it very slightly because I don't want to take away pathology. That could be blood that's layering down. It could be pus that's layering down. Okay? It could be just debris. Now, if it's debris, it should move, right? So what am I gonna do? I'm gonna roll my patient up to see if it moves. Okay? Here's PID, complex adnexal masses. Huge infection. Here is my uterus. So this is a transverse transabdominal image with bilateral
NXMS.
Pathology. Okay. Advanced PID.
COA.
You have escape of purulent exudate. What does that mean?
Something from
Yeah, it's just a pussy mucus stuff that's gonna escape the fallopian tube. But it can go both ways. It can go out into the peritoneum, or it can go into the endometrium. And if it's in the endometrium, it can come out through the cervix, and there's my discharge. Okay? A TOA always involves the ovary, because we can't tell the difference between the tube and the ovary. It just looks like a huge mess. Like this, that's a huge mess. You won't be able to separate the ovary from the tube. That's when you do superior, mid, inferior, lateral, mid, medial, do a cine, and you're done. Don't spend a lot of time maneuvering the transducer, because more than likely the patient is going to be very sensitive.
The picture you just showed, is that two ovaries almost touching each other?
Oh, I don't know.
That,
Doesn't look like it.
oh.
Well, it could be. This looks like an ovary, because it looks like it has follicles around it. So I don't know. What does the picture say? Okay. Okay. So the difference between a TOA and a TOC is, with the TOC, I can still see my ovaries. I can actually define where they are. It just says adnexal masses. So here's my ovary, and this is close to the ovary. Here's my ovary, because I can see tissue. And then I have a mass that is adjacent to the ovary. So this would be a TOC, because I can still see the ovary. A TOA, I can't see the ovary.
Shepherd, how are you able to differentiate between the two, between the mass and the ovary, the follicles?
The follicles, because I see tissue. You see tissue here? I don't see tissue here.
Okay.
So this is the ovary. Here's a follicle, here's a follicle, here's a follicle.
But isn't there a time where women don't have follicles?
No, we always have follicles.
Always?
Mhm.
Regardless of
Yeah, unless you're postmenopausal.
yeah, postmenopausal.
Yeah, postmenopausal, you shouldn't have follicles. If you have follicles postmenopausal, they're gonna put me on birth control pills to see if my body can get rid of those follicles. If they don't, they're gonna have to do something else. Because I shouldn't have follicles if I'm postmenopausal. Okay? So, here's a TOA. You can't, here you can see that's probably an oviduct, which is just another name for fallopian tubes. Okay, you really can't see any ovarian tissue. Chronic PID, I'm gonna have a hydrocephalus. Okay, it's a sausage shape that's anechoic, it's in the adnexa, and you're gonna see those hostra or incomplete septa. Okay, the wall thickness is going to be less than 5 millimeters, and you can have a hydrosalpingi torsion, because the fallopian tubes also have to receive blood, because the cells of the fallopian tube have to receive blood to keep it alive. That blood supply can also turn, and then you lose blood supply. Okay? We already know that that can happen with a ovary, right? An ovarian torsion, it gets adenomous, it's gonna get big, and it's usually gonna get round. It's gonna get very fluffy looking, adenomous. Okay, chronic PID, hydrosalpinx, you can see the septa. See a little bit of debris here. Hydrosalpinx. Okay, this is CT. This is MRI. These are different imaging modalities. CT and MRI. This is cross-sectional. This is cross-sectional. Okay? MRI, fluid is white, black.
Which one is CT?
This is CT. This is MRI. The T factors are going to be different. So here it's the exact same patient, but you can see that the organs are seen better on the MRI because MRI is best for what pathology? Adenomyosis.
Tissue.
Because adenomyosis is in the uterus, in the myometrium.
What's the purpose, I'm sorry, purpose of the CT?
Most people, they're gonna order a CT because it's so quick to do and whatever, okay? But MRI is the best for in adenomyosis.
Is CT the best for something? Only because the picture that I saw those in.
Yeah,
I can see the figures of the
CT has
organs.
its benefits over MRI, and MRI has its benefits over CT. Okay, but MRI is very, very expensive. You usually only have 1 or 2 units in the area, because the machines are very, very expensive, and so it takes longer to
1 hour at least.
have the exam. Plus, it's a harder exam to go through because you can get claustrophobic.
Yeah. They won't
Okay.
stay still.
Yeah, it's hard to stay still. Endometriosis. It's endometrial glands and stroma outside of the uterus. Okay? So it's going to be in my peritoneum. This is everywhere where it can implant.
Mm.
Everywhere you see a black dot, they can find implantation. This is what it looks like on biopsy. You have 4 stages of endometriosis. Stage 1 is minimal, stage 2 is mild, stage 3 is moderate, and stage 4 is severe.
Severe.
Would that be severe? Absolutely. Peritoneal lesions. Why are they calling it peritoneal lesions? Yeah, because it's in my peritoneum. Okay? So they can vary in size from millimeters to centimeters. This is a lesion. Okay? They vary in echogenicity, hypo to hyper. They vary in location from the bladder to rectovaginal. What does that mean? Yeah, rectum and vagina. The septum, the uterosacral ligaments. Where are those? What do you think they'll be? The uterosacral ligaments. Probably my pelvic floor. Okay, because it's holding the uterus to the sacrum. Okay. Endometrial, if it's ovarian lesions, you'll have an adnexal mass with peripheral Doppler flow. You'll have a thick wall. Be homogeneous or low level echogenicity. It'll be unilocular, but it could have septations. The fluid level, and it would be gravity dependent. You could have central calcifications if it's old. Okay? You can have echogenic foci. What's an echogenic foci? Nope. It's a tiny little hyperechoic dot. Okay? Echogenic foci. They usually don't shadow. You could have small peripheral cystic structures with hyperechoic margins. Endometriosis.